Hey everyone, it's good to be back. I'm going to start making some shorter, sharper videos. They'll be more to the point and they're going to be in relation to clinical situations we find ourselves in every day of the week. And so I'm opening with a series about common electrolyte abnormalities. Now, before I start, I just wanted to mention some great work that's being done by one of my colleagues, Dr. Clem Chow. So Clem's developed this great website called The Pocket Doc. It's all about providing open access resources to support you and your clinical decision making on a day-to-day basis. I'm putting the link right here. This is what the website looks like. It's got all sorts of great resources. Click on it, have a look. We're going to be hoping to collaborate a little bit more in the future and add some more resources very soon. So our first topic in this series is hyperkalemia. It's a good topic to know about at all levels of medicine, whether you're a medical student, junior medical doctor, a bit more senior in your training, because of its potential to cause life-threatening cardiac arrhythmias. So as an outline, we'll be running through the physiology of potassium homeostasis, the etiology, consequences, and management of hyperkalemia. Now, before starting to talk about any electrolyte abnormality, it's absolutely fundamental to understand where fluid sits in our body and exactly where we're measuring these electrolyte concentrations. So 60% of our body is actually made of water, and we can divide this 60% into functional compartments. So 2/3 of our total body water sits inside our cells. That's the intracellular compartment. And the remaining 1/3 sits outside the cells in the extracellular compartment. Now, the water outside the cells can either sit in the intravascular space, and that's the plasma, and 25% of the 1/3 sits in there, and the other 75% sits outside the vascular compartment in the interstitium. And when we measure our serum electrolyte concentrations, it's obvious that we're going to be measuring them in the plasma, and that it's also important to realize that these fluid compartments aren't static, they're dynamic, and the movement of water between them is going to affect our serum electrolyte concentration. So getting back to potassium, our serum potassium concentration is determined by our level of potassium intake, the distribution of potassium between the intracellular and extracellular compartment, and our excretion of potassium through the urine. Potassium intake is quite straightforward in the sense that it's absorbed through the intestines when we have foods that are rich in potassium. The distribution of potassium between the intracellular and extracellular compartment is quite interesting. Potassium is primarily an intracellular cation, and its intracellular concentration, which we never really measure, is around 140 millimoles. Extracellularly, this is the reading we're used to seeing. It's around 3.5 to 5 millimoles in the serum. And we can always think of sodium and potassium as opposites in the sense that sodium is an extracellular cation. Its serum concentration is between 135 and 145 millimoles normally. And how is this intracellular, extracellular concentration maintained? It's through this pump which sits on the cell membrane. It's the sodium potassium ATPase pump. It uses ATP to drive sodium out and bring potassium in a 3:2 ratio. And that maintains our normal concentration of electrolytes in the intracellular and extracellular space. Now, this pump, its action is enhanced and is only possible because of beta-2 adrenergic stimulation and stimulation from insulin. So that's very important to remember in terms of both causes of hyperkalemia and treatment of hyperkalemia, which we'll get to in a second. So potassium excretion. As I mentioned before, potassium is excreted through the urine, and this is primarily determined by the secretion of potassium by the principal cells of the collecting duct. Now, where's the collecting duct? That's the bit of the nephron that's right at the end. And at that part of the renal tubule, you have principal cells that line the tube. And that's the diagram we're looking at now. Let me explain this to you. So this is the tubular lumen. This is where sodium, water, essentially the filtrate from the glomerulus of the nephron comes running down, and is eventually, if it keeps running down that way, will get to the renal pelvis and the ureter down towards the bladder where it will go out as urine. These are the principal cells, and they're just like any other cells in the body in the sense that they have our favorite sodium, potassium, ATPase pump sitting on their surface, and they separate the tubular lumen from the peritubular capillary, which is our normal serum. Now, what happens? As usual, because this is a cell, it's going to push sodium out and bring potassium in, and this is going to be rich in potassium inside. And the filtrate coming down the tubular lumen is going to be full of water, of course, but also full of sodium. And when sodium gets to this part of the nephron, this part of the tubule, it starts to find sodium channels on the wall of the cell. So it flows down its concentration gradient into the cell because there's a heavy concentration of sodium here and no sodium in here because it's intracellular, so it starts flowing in. And as usual, because they're opposites, to maintain electroneutrality, potassium starts flowing out and is excreted into the tubular lumen. And that's how we actually get rid of the potassium. The sodium comes in, and the potassium from the cell goes out. Now, what enhances this process? Aldosterone. And how does aldosterone enhance this process? One, let me just get rid of all this writing. One, aldosterone increases the amount of sodium channels. So it allows more sodium to come in, which means more potassium has to go out. And the second thing that aldosterone does is it increases the amount of sodium potassium ATPase pumps on this aspect of the cell to bring more potassium in to let more potassium out. So essentially, we always know that aldosterone's at the end of the renin-angiotensin aldosterone axis, and its primarily function is to put more sodium channels in, to conserve sodium, and water will follow sodium because of the osmotic gradient. But it is also fundamentally important to get the potassium out. And that's the key message from this diagram. So if we understand that, the etiology of hyperkalemia is going to be very straightforward. I have to start by saying hyperkalemia because of increase of potassium intake is very rare. And it's only really when you've got problems down the line that it becomes a problem. So I wouldn't even classify it as a cause of hyperkalemia. The two big ones, A and B, are because there's an impaired distribution of potassium between the intracellular and extracellular compartment, i.e. there's an increase in release of potassium from cells, or there's a problem with your potassium excretion in the urine. So they're your big two categories of causes of hyperkalemia. Let's start with category 1, increased potassium release from cells. Why does it happen? The first one to be wary of is a pseudo-hyperkalemia. What does pseudo-hyperkalemia mean? It means that your reading shows that a potassium level is high, probably above 5, but is the systemic serum potassium concentration above 5? Probably not. And the two main reasons we get pseudo-hyperkalemia is because of prolonged tourniquet times. Sometimes in patients it's hard to take blood from, you keep the tourniquet on for longer, and because of the conditions the cells find themselves in, being downstream of a proximal occlusion, they tend to release potassium. The other reason is when patients pump their fists excessively, that the exercise they're doing induces a potassium release from cells. Is it a hyperkalemia in that part of the blood you're measuring? Yes. Is it a hyperkalemia systemically? No. So that's a spurious reading, and it's one you have to be wary for because of different venipuncture techniques. Now, the big ones, these ones are the ones you have to know about. Metabolic acidemia. Why is a metabolic acidemia going to give you hyperkalemia? This is why. So, metabolic acidemia, you have more H plus ions in the blood, and your body will naturally try to buffer those H plus ions by moving them intracellularly to buffer them with bicarbonate. Now, to maintain electroneutrality again, potassium comes out because the hydrogen goes in. That's why metabolic acidemia gives you a hyperkalemia. Lactic and ketoacidosis don't tend to give you that, and the reasons for that are a little bit technical, and you can read them up if you wish, but it's probably not that important to know exactly why, just that they don't tend to give you a hyperkalemia, and you don't tend to get as much of a hyperkalemia from a respiratory acidosis. So it's your metabolic acidemias minus your lactic and ketoacidemias. The next one is if you have an insulin deficiency. Now, we remember the sodium-potassium ATPase pump that drives potassium intracellularly works because of insulin. So if you have an insulin deficiency, that's not going to work. Hyperglycemia can be related to insulin deficiency, but on its own, it's got its own little reasons why it leads to hyperkalemia. Let me show you why. Say this is a cell, and say you've got a lot of glucose on the outside. The first thing that's going to happen is because your serum osmolarity is increased, water is going to come from inside the cell out of the cell. And what does that mean for the potassium inside the cell? Well, it means that the intracellular potassium concentration gets higher because water is leaving the cell. So potassium tends to come out to sort of move from a high concentration area to a low concentration area. The other reason potassium comes out is because of this phenomenon called osmotic drag, where the water pulls the potassium out with it, and it increases the potassium extracellularly. So that's insulin deficiency and hyperglycemia. Non-selective beta blockers, as we said, the beta-2 adrenergic receptor is responsible for the sodium-potassium ATPase pump. So drugs like propranolol, labetalol, we've got to be a little bit worried. And lastly, increased tissue catabolism. So in cases of trauma, tumor lysis syndrome, where cells are crushed and the intracellular ions get leaked extracellularly, you can get a hyperkalemia. Particularly trauma, when you have large crush injuries and things like that, you have not only, everyone thinks of rhabdomyolysis, but in the acute sense, you have potassium leakage that can be quite devastating initially. So what about causes of reduced potassium excretion? And as I said before, aldosterone is really the key here. It's that hormone secreted by the adrenal glands that acts to put more sodium channels on the principal cells in the collecting duct and more sodium-potassium ATPase pumps on the basolateral surface of those cells to allow more potassium out, more sodium in. Now, low aldosterone secretion can be because of low renin release. More commonly, what we see is patients on ACE inhibitors, angiotensin receptor blockers that stop the production of aldosterone, or adrenal insufficiency. You can also have reduced response to aldosterone, and there are quite a few pharmacological agents that actually do this on purpose. So the potassium-sparing diuretics like spironolactone actually work like this. So they block the aldosterone receptors, and because of that, they stop sodium reabsorption, and they keep the water in the tubule to induce a diuresis. And because they do that, they do all that, they don't let potassium to come out in exchange for sodium. And, kidneys that are damaged can also not be responsive to aldosterone, not carry out their functions properly. And finally, if you don't have delivery of sodium and water to the distal tubule, in cases where you have intravascular depletion, like, when you have got excessive losses through either the kidney or the GI tract, heart failure where your fluid isn't being pumped in the intravascular space, or cirrhosis where it's all sitting in the interstitial space, you're not going to get enough sodium in that distal tubule, in the collecting duct, to move across in exchange for potassium, so you can get hyperkalemia as a result. And the obvious one, I guess, is if your kidneys aren't working, you can't get anything out. So potassium will be one of the key things you have to be wary about in a patient with acute or chronic kidney disease. And particularly those patients with severe acute kidney injuries and those patients who are pre-dialysis or have missed a dialysis, you don't want to miss them, their potassium being high. So how does hyperkalemia actually physiologically affect us? What's the consequence of this? Well, you might remember the Nernst equation, and this is getting back to first principles of physiology, but simplified, the Nernst equation simply reflects that the resting membrane potential of a cell is determined by the extracellular to intracellular concentration of potassium. Now, we said before, normally your intracellular concentration of potassium is high, and the extracellular concentration of potassium is low. But if you have movement of intracellular potassium to the extracellular compartment, these ratios start to get closer and closer together. And because of that, because the ratios decreased, you start moving your membrane potential closer to the threshold potential. And what that does is increase membrane excitability and give you an increased chance of depolarization. And you can think about how that can be very important in things like your muscles, particularly your cardiac muscle and your cardiac myocytes, which are obviously very important that they depolarize at the right time in the right way to allow good ventricular contraction. Now, later, once they've been depolarized enough, persistent depolarization inactivates the sodium channels and you get decreased excitability. And as a result, you can get all kinds of arrhythmias. So we've talked about physiology, we've talked about etiology. What are the clinical manifestations of hyperkalemia? Now, generally, your potassium has to be a fair bit higher than 5 to start getting manifestations. And typically with people with chronic hyperkalemia, it has to be above 7, but it can be a bit lower in people with an acute rise in their K. And the main ones you get are severe muscle weakness / paralysis. And this muscle weakness, it's quite distinctive in the sense that it's ascending muscle weakness that starts with the legs and progresses up the arms. Your sphincter tone and your cranial function, nerve function is often preserved, and the respiratory muscle weaknesses are is very rare to be involved. So it's unlike GBS in that sense. And the main ones you're really worried about are the cardiac manifestations, and you can get all sorts of conduction abnormalities and arrhythmias, bundle branch blocks, bifasicular blocks, AV blocks, sinus bradycardia, VT, VF, asystole. So these are the ones that are life-threatening and that we really want to watch out for. So what are the ECG changes that we need to look out for? Generally, we're taught that there's an evolution that starts with peak T waves, shortening of the QT interval, lengthening of the PR interval, lengthening of the QRS complex, eventually disappearance of the P waves, and eventually after that, the dreaded sign pattern. Now, the progression, it's very important that when we're sort of trying to look at the progression of the hyperkalemia or the response to treatment, we don't use the ECG changes because they don't correlate well with the serum potassium concentration. What we should look at them for is for what they are. They're ECG changes that may need treatment. So what's our clinical approach going to be with these patients? We need to be wary of the patients that are at risk of having hyperkalemia, and that's when you should be running through those etiology categories in your mind. Increased potassium release from cells, reduced ability to excrete potassium through the urine. In these patients, get them on ECG monitoring straight away and do a rapid screen for symptoms and signs of muscle weakness. And ECG changes will indicate that you should be administering therapy urgently and that you should be getting a venous blood gas, arterial blood gas as quickly as possible to get a rapid reading of what the K might be. but the ECG changes should not be used to monitor the efficacy of your hyperkalemia therapy. So we've talked a lot about physiology, and the management, if we understand all that physiology, the management fits in really easily. It's like the final piece of a puzzle. So the first thing we do when we're managing a hyperkalemic patient with ECG changes, the first priority is to stabilize that myocardium. And what stabilizes that myocardium? For reasons that aren't exactly clear, it's calcium. So there's two choices. We can give calcium chloride, calcium gluconate. Which one's better? Well, calcium chloride has 3 times the amount of calcium as calcium gluconate, but it's very difficult to give through a peripheral vein because it can be A, very irritating, B, it can cause necrosis and collapse of that peripheral vein, so we don't tend to give it unless we have a central line in, which on the wards we won't. So calcium gluconate is the go. Next priority, as we said, drive that extracellular potassium into the cells. And what we typically use is insulin and glucose. The insulin, as we've said, drives that sodium potassium ATPase pump. It drives the potassium intracellularly. Why do we give the glucose? So they don't get hypoglycemic as a result of the insulin. Now, if the patient is hyperglycemic, like their sugar is above 13.7, I see some guidelines say, you can just give the insulin by itself. The other things that we don't tend to give as much are beta-2 adrenergic agonists, and I'll tell you where I have seen a patient get beta-2 adrenergic agonists. We had this large lady who was very difficult to cannulate, who had a potassium of 8.1 and ECG changes, and while we were getting an ultrasound machine, we just gave her some nebulized salbutamol for what it was worth. Not sure how effective it was, but physiologically it made sense. The other thing we can do is try to neutralize an acidemia, and we can do that with something like sodium bicarbonate. Then the next priority after that is to remove the potassium from the body, because all we're doing with these sort of treatments is shifting the potassium around. We have to actually, if we have a total body excess of potassium, we have to actually get rid of it. And the best way to do that is loop or thiazide diuretics. And what these essentially do is they preserve sodium and they keep it in the tubules so that they can get to the distal nephron, to the collecting duct, and be exchanged for potassium. And we tend to use loop diuretics in patients who have normal kidney function to slightly mild to moderately impaired renal function, and thiazide diuretics only in people who have good kidney functions. The things that work a bit slower are the cation exchange resins, which are given orally. They'll stop you from getting more hyperkalemic, but don't really affect you by just sort of binding all the potassium in the gut. But they don't sort of lower your serum potassium very well. And for patients that are sort of refractory to medical treatment who have bad kidneys, we go to haemodialysis. So these are from the Australian Therapeutic Guidelines. This is the stepwise approach they recommend. They say if you have a hyperkalemic patient with ECG changes, the first step is to stabilize the myocardium. IV calcium gluconate, 10%, 10 mils over 2 to 3 minutes in a large vein. It can be quite irritating. And because the effects of this are quite transient, you may need to repeat in 30 to 60 minutes. This buys you some time. And they recommend the next step is to restore your intravascular volume to get delivery of sodium and water to that distal nephron. And you can do that with sodium chloride, particularly if your patient is hypovolemic or even euvolemic. Or if you have an acidemic patient, you can give some sodium bicarbonate for what it's worth to try and neutralize that acidemia and stop the hyperkalemia because of that. Then to drive the extracellular potassium into the cells, we use short-acting insulins like Novorapid and with D50 dextrose over 5 minutes, or we can give lower concentrations of dextrose over longer periods of time. So that's driving the potassium into the cells. How do we get rid of the potassium from the body? Well, there are these exchange resins that I mentioned before. They sit in the gut, bind all your potassium, or you can also give retention enemas. But most of the acute management you'll be doing on the ward in the emergent situation, in the emergency department, will be these 3 steps. This stuff, slower, it just sort of is ongoing management. And remember, the final option, when your medical therapy isn't working, when there's extensive tissue breakdown and there's a sense of urgency that you're not going to get on top of the hyperkalemia, or there's irreversibly poor renal function, you need to dialyze.